So Ash, this year we're going to see data on the MCL-R2 Elderly clinical trial. So this is a European mantle cell lymphoma network study. There are two randomizations in this study. The first randomization is between a standard R-CHOP given 3 weekly for 8 cycles versus R-CHOP alternating with rituximab, cytarabine, and dexamethasone. So R-DHAD. Regime. And this is randomization, therefore, in older patients, generally patients over 60 who are not considered suitable for autologous stem cell transplant. So that is the first randomization in that study. And then patients who respond to either regime go on to a second randomization where patients are randomized between either rituximab maintenance, we've been used to using that in mantle cell lymphoma in older patients after R-CHOP for a number of years now, or rituximab plus lenalidomide. Lenalidomide as itself is an active drug in mantle cell lymphoma and, of course, synergizes with rituximab. So asking two really very important questions. Does cytarabine-based induction improve outcome in elderly patients? And number two, does lenalidomide add benefit in the maintenance setting in older patients with mantle cell lymphoma? And the first randomization was negative, so there's no difference in terms of disease response rate between the two arms. That's an important question, also looked at and answered. The second randomization, very intriguingly, shows quite a benefit to the addition of the lenalidomide in the maintenance. So the 4-year progression-free survival was 61% in the R-squared arm and just under 43% in the rituximab-only arm. And so really showing that lenalidomide provides quite a degree of benefit here for patients in this setting. Now, of course, this isn't a formally licensed or approved therapy in this setting in mantle cell lymphoma, so there may be some issues around access of this combination. But in countries where access is less of an issue that can access R-squared here, it may be of benefit to older patients. Of course, this comes at a cost. One might expect R-squared to be more toxic than rituximab in this setting, and that is the case. More cytopenias, more infection, more cutaneous toxicity as well. And interestingly, at this follow-up, 2-year overall survival data is no different between the two arms, not statistically any different. So a trade-off of efficacy and toxicity, as we often see in hematology, but certainly a striking difference in progression-free survival in this study. So again, I'm sure this abstract will cause a lot of discussion at ASH.